Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. This is a platform where research meets understanding and legacy. Recurrently on this platform, we've discussed HIV, we've discussed COVID-19, we've discussed other infectious diseases. But today we are going to the state of Port Harcourt. I don't say city of Port Harcourt. We are going to River State to look at the correlation between COVID-19 and HIV. Research was done during the pandemic to know how people living with HIV perceived the COVID-19 vaccine and also the acceptance of COVID-19 vaccines across the state. So please join me to welcome Mr. Korfii Uebari. I hope I pronounced your name right, Mr. Korfii. Or is it Korfii?
Yeah, Korfii. I think you did pronounce well.
Okay, Korfii. Actually, when I first came across the name, I was like, this, to me, it's a beautiful name. Simply, in simple words, what's the meaning of your name? So in case of next time I come across another Korfii.
The meaning is conclusion, but there are different variants, right? This is the Ogoni part of River State variant. There is also the Ghana variant. So that's the one that is common. It's common more in Ghana than in Nigeria. So the Ghana own, from stories around, they said they may relate, but I have not paid attention to look at what they mean together. But from my tribe, it means conclusion.
Okay, thank you so much for that. So, global citizens, let's quickly look at the biography of Mr. Korfii Uebari. He is a multidisciplinary researcher with over 10 years of experience supporting health research and programs across Nigeria. His work spans maternal and child health, reproductive medicine, HIV and AIDS, COVID-19 vaccine uptake, mental health, environmental health, and health system strengthening with a strong focus on evidence-based research and translating evidence into policy and practice. He holds a Master of Science in Environmental Chemistry from River State University and a Master of Business Administration from Miva Open University in Nigeria. He is currently completing a Master of Public Health at the University of Port Harcourt, as well as a PhD in Environmental Chemistry in River State University, Port Harcourt. He also has several public health certificates from University of Washington through its global health e-learning platform. And McGill, I was corrected on this, McGill University, Canada, and the Barcelona Institute of Global Health. He has a quite extensive profile, but we'll just read just this. Thank you so much, Mr. Korfii Uebari, for gracing us with your presence on this topic for today. Before we dive into the questions, let's quickly look at what global citizens are saying about COVID-19. I didn't intentionally go into HIV/AIDS because this is the post-pandemic, and interestingly, people are still talking about the pandemic. So let's see what global citizens are saying about COVID-19. The first is from Joma Jikanen, where he's saying the so-called COVID pandemic was a WHO, DARPA, WEF, NATO, Health Department pandemic, classifying flu as COVID-19 virus used to kill with remdesivir and respirator suffocation to usher in killer mRNA PGM globally. So there are still people that believe the COVID-19 pandemic is not a pandemic, it's a pandemic, that it was curated to infect global citizens. The next, the next tweet is from UN News, where they are saying children in Eastern DR Congo could become increasingly affected by the worsening Ebola outbreak, UN agencies warn. Although Ebola can be deadly, it spreads very differently from COVID-19, meaning schools can remain open. So UN they are comparing the COVID-19 pandemic and Ebola pandemic, how the citizens are responding to it. And I believe Ebola has happened currently in Congo, even though I don't want to like put it as a stain on them like they are used to it, but I believe they've adapted and made adaptive strategies to be able to help their citizens to even continue their day-to-day activities in the midst of a pandemic or in the midst of an outbreak. So lastly, the last tweet is from Philly, where she's saying modern life involves persistent stressors like the aftermath of the COVID-19 pandemic, with a measurable increase in recognition of trauma and PTSD. This causes different levels of symptoms. Some people are unable to work. Some people work and still get PIP. So even though the COVID-19 pandemic is over, even though people have stopped talking about the COVID-19 pandemic, some people are still getting the aftermath, getting PTSD and other symptoms from the COVID-19 pandemic. For me, I've moved on. I don't have any symptoms from the COVID-19 pandemic. When you see me talk about COVID-19 pandemic, it's about research. Yeah, so now diving into the discussion, Mr. Korfii Uebari, my takeaway from the COVID-19 pandemic was it was like a sudden accident on other accidents on a collapsing bridge. If you've come across anywhere I spoke about COVID-19 pandemic, I've mentioned this sentence repeatedly because I just feel that's the best description. I came across it when I did a course during the pandemic at Harvard online program, something like that. And that made me the way during the program, it was a discussion between two physicians and they were comparing Ebola and the COVID-19 pandemic. And that was the first time I was hearing and learning from the COVID-19 pandemic differently. And it made me appreciate Harvard. Since then I've been saying Harvard is Harvard for sure. And I'm not biased to the university I finished from and other universities across the world, but Harvard is Harvard. And yes, Harvard is Harvard because of how they approached it. I saw COVID-19, as I said, is an accident, a huge accident that met other accidents on the collapsing bridge. The collapsing bridge is our health sectors globally because even the global north was affected greatly by the pandemic. Now, what I found more interesting was that your research, younger participants were a majority of your participants, if I'm right, and they were the least, I don't know, you can correct me, they were the least receptive. Younger people who are living with HIV, they were the least receptive to the COVID-19 vaccine. Now, today we are discussing two viruses individually, the COVID-19 virus and also HIV. Mr. Korfii Uebari, what are the myths in Rivers State regarding the COVID-19 vaccine?
Okay, so can you hear me well?
Yes, I can.
Okay, yeah. So the thing is, there are several myths as in regards to what happens in Rivers in terms of COVID-19 vaccines, right? And one of them was the fact that participants have rumors around the whole thing that the vaccine was created to reduce the world population, and that it was also designed to kill people who take the vaccines. And also, a lot of other people have said that it's some sort of global political agenda. And interestingly, some other people see it as a disease that affects only the wealthy people, or more like kind of the white that, foreigners, then is not for, Africans. But there were also two key things that was running concurrently in between all of these myths. And this is what Africa is. religious and traditional beliefs. So they were also, these two terms also, have their underlying myths, across all of these things. Where some believe that they are divine, like, they are protected by God, and none of these things will get to them. Just like the last one we published from the research says that I didn't believe it was real. So nobody in all of these focus groups that we did, as well as the quantitative that we collected, actually pointed to say they believe that these things were real. So each of them have different things that runs through them at every point in time. And then, people were also made to believe that if they take these vaccines, it's going to make them infertile. And so many sort of those things. And these are things that comes from the community at large, both different communities. But although our focus was just tied to what we have called the key population in this for the research, who are just majorly female sex workers, people who inject drugs, and men who have sex with men. Yeah. So that's the summary of what we see as the myth that was foundational for the research or the study we did.
Thank you so much for that, Mr. Korfii. When we're talking about HIV in Nigeria, one of the states people look at is Rivers State. And thank you for doing this research in Rivers State. Now, there is a clinical picture before the pandemic. There was HIV in Rivers State years before the COVID-19 pandemic. Tell us, paint for us a clinical picture of HIV in Rivers State before the pandemic and during the pandemic.
Okay, thank you. Yeah. Okay, so I will start by saying that so even if I'm not a clinician, right, but before the COVID-19 pandemic, University has already carried a substantial HIV burden with an estimated HIV prevalence of approximately 9.1%, making the state one of the most significant HIV state with one of the most significant HIV challenges in Nigeria. And this HIV prevalence as at before the COVID pandemic got across both general population and key population. Then during the pandemic, these vulnerabilities became more pronounced, where we see people who have HIV and then they were managing HIV, and then you now come to talk about COVID-19 in the picture. These are two complex things to manage if you look at it from the other side. So there are so many other things, but from what we saw in the research, there were disruptions. You can remember that there were lockdowns. So what does the lockdown mean? As to somebody who needs to go to the hospital or to a center to collect his or her ART drugs. It means you have to struggle with movement, even though there were some exemptions in some states where what they call essential services, but it does not apply to the people who want to come to take drugs, right? So they were faced with that difficulties. And again, too, for when the vaccines was rolled out, it has to be a national rollout. Everybody needs to take vaccines. So that now take us to thinking around people who have been taking HIV drugs, and now you are asking them to take vaccines. So there was some sort of questions around, do these vaccines interact with HIV drugs that they take? Though some other clinical trial research may have been done to show that taking the vaccines may not disrupt taking your HIV drugs. But to a layman, to somebody who does not understand these things, how do you explain to that person that taking vaccines with so many misconceptions is not going to affect the drug? So there was also that thought about the HIV drugs as well as the vaccines interaction. But in between the line, there are no, let's say, comprehensive study that shows what the prevalence looks like during the vaccines. So clinically, what we only could layer onto is how the COVID-19 pandemic affects, meeting up with HIV, drugs pickup, as well as some other things that is required for management of HIV for these people. Yeah. So that's what the picture looks like. Like I've mentioned before the pandemic, we had a very high body in HIV in the state, which was 9.1%, as mentioned earlier. Well, currently now, I mean, I do not have a picture to what the percent looks like. It may be reducing because of, proper management. But like I said, all of these percentage thing, HIV burden analysis comes with huge national surveys, and which was not done in between the pandemic. Yeah.
Mr. Korfii, just give us a candid reply to what the clinical picture looked like for people living with HIV before the pandemic and in the pandemic. Now, for not just the COVID-19 pandemic, but focusing, of course, on the COVID-19 pandemic, but with focus on River State, aside people living with HIV, what other groups were affected during the pandemic?
Okay, so several other key populations were affected during the COVID-19 pandemic. And I would just like to point to the fact that these challenges people face were due to socio-economic as well as health-related vulnerabilities. I usually front and see healthcare workers as also key populations in most instances. And then tied to our discussion today, HIV and COVID-19, right? Healthcare workers were also at risk because of they were directly exposed to some of these things. In some key contexts, some people may not see healthcare workers to be a key population, but myself, I see them as the first. So I was starting to establish the fact that the healthcare workers were some of what we can also say as key population who faced or who were affected during the pandemic. But diving deep into what actual key populations would be, older adults and individuals with chronic conditions like diabetes, hypertension, and some other cardiovascular illnesses were also affected. Then you cannot talk about key populations without talking about pregnant women. So they were also affected because in so many cases, antenatal visits were interrupted during the COVID-19 vaccines. So everything was just more like not going for immunization, as well as some other essential healthcare services they should have needed during those processes. Then we fall back just to add more to it. So other people who face challenges were internally displaced persons, because the services they get on the normal working day activities were limited. So people could no longer come to take care of them. So it was just them for themselves in the camp. And then another, because there are IDP camps in River, just to shift the talk to the fact that I'm not mentioning people who are not in River State. There are IDP camps in River State as well. And then we also would say that people in closed settings, people in prisons. I think Port Harcourt has about 4 different prisons with 1 maximum prison. So they were also key populations that were also faced challenges during the COVID-19 pandemic. Then there's what we call the OVCs, orphans and vulnerable children. So they, in part of the HIV program, so you have an element of what they call the OVCs. They also face similar challenges, and then there are key populations too who were affected during the COVID-19 pandemic.
You highlighted the other groups aside people living with HIV who were affected during a pandemic like the COVID-19 pandemic. And if you realize when you were speaking, I was a bit teary because that is one of the focus of my career, disaster management. And you mentioned orphans, vulnerable children, internally displaced persons, prisoners, and in every setting, even though government policies try to highlight them, try to prioritize them, these are people in our societies that are often overlooked. So thank you so much for highlighting other groups of individuals who are also greatly affected during the COVID-19 pandemic. I'm tearing. I even see the tears in my eyes. I'm quite emotional this morning. So now, moving to the next question, Mr. Korfii Uebari. Now, the COVID-19, during the COVID-19 pandemic, I personally discovered that strains were, we kept getting new strains. They were like strain, different names. I don't know if it happened in Nigeria, because I was not in Nigeria during that period. New strains, we were like, hey, we are finished. So let's say a new virulent strain of COVID happens tomorrow, start infecting individuals tomorrow. Will there be a change in the uptake of the vaccine in River State? And why do you think there will be a change in it?
I'm going to respond based on the findings, from the study we did, right? Because there are so many studies cast everywhere, and then, different answers. But specifically based on what we did, I think that vaccine uptake will likely improve compared to the initial COVID-19 response. But hesitancy will still persist. It will still persist even more than we face. But I'm not compromising the first statement anyway. But the point is this: this will happen because primarily the identified issues around hesitancy have not been addressed, and then different populations. The population I studied are some sort of a peculiar population, right? Peculiar in the sense that they don't mix up with the general population when they want to access health services. So most of the things they do are, done through the different channel, let me just put it, to their own communities. And these folks need to build trust in healthcare providers. So if you're asking them to go and collect vaccine in a public health center, how do they trust these persons? Female sex workers, people who inject drugs, and even men who have sex with men. You understand the way they behave, and especially men who have sex with men. So when you see a man walking like a woman coming to your facility, the healthcare worker, how would they accept that kind of man? So they need to build that trust in the healthcare system, and as well, what we need to do has not been done, like I said. And one of them is a comprehensive healthcare campaign across the state to address misconception. Because what drives COVID-19 uptake or acceptance is when you change people's perception about a thing. But if that is not changed, the uptake will not be as it should be. In the study we did, we saw about 54.1% uptake. It was not below 50, but it shouldn't be that number if we have done all of these things that I have mentioned. Then again, you see that there are barriers that remain key, and that's around misinformation, distrust in government. You see, if you're in Nigeria, you will see the way things have been done in Nigeria, where even citizens don't trust government people. So they feel like whatever they want to do is not to the benefit of the citizen, but to their own benefit. So these are the things that affect COVID-19 vaccines or any other vaccine uptake. So if I even want to push a big to vaccination at large, so it's not only about the COVID-19 vaccine that has these issues. So many other vaccines, even the one we give children to in some countries, in some states, have these issues of acceptance because of different beliefs and all of that. Then, to add to what we have said, economic challenges and the access barriers are more a problem to acceptance of vaccines. Like some of the findings we have outlined here, you see that people don't have access to the vaccine. So let's recall back to when they said the vaccination. People believe that it was for rich people. And some people say when they go to the hospital, they cannot have access to the vaccination. People who can access, say they were asked to be paying money. And from my own understanding, that vaccination rollout was completely free. And then you see it, people start asking people money. So it's still going to push people out of it. So in summary of what you have asked, yes, I believe that it may increase. It may increase because some people, I mean, people get enlightened every day. But like I added a clause on it by government with more WHO vaccination. So it is believed that everybody should be vaccinated and then nobody should be left out. But we see cases where more numbers turn down vaccines, right?
Yes, Mr. Korfii, thank you for discussing that extensively. When I was reading the paper, I came across different vaccines, and what your paper is about the gaps during vaccine uptake, especially for people living with HIV. So, what vaccines were actually available to River State citizens during the pandemic? What COVID-19
So,
vaccines?
I mean, about 4 vaccines are available in the state, though they come on in different batches. All the 4 were not at the same time, but at the end of everything, I mean, 4 vaccines were available for people to come and get vaccinated. And we have Pfizer Biotech was available, and the Johnson and Johnson came, Moderna came as well, then AstraZeneca also came. So these were the 4 vaccines reported to have been received across the state. I do not know whether other states have different other COVID-19 vaccines in country as at then. But for Rivers State, these were the 4 vaccines that were available in the state.
I think I have to commend not just Nigeria government, but also River State government for making sure 4 vaccines were available. I don't know how many places had 4 vaccines available to them, COVID-19. I don't know, maybe it's across Nigeria. But where I was, vaccines were not readily available to the best of my, like they didn't have access to the 4 vaccines. And it was a really urban area. So you now saying you had access university to 4 vaccines is quite impressive. So, Mr. Korfii Uebari, what strategies do you have or will you recommend to tackle vaccine hesitancy, not just in Rivers State, but in Nigeria?
Okay, so I will start by saying that I do not have strategies, I mean, to address vaccine hesitancy. The people that have strategies to address vaccines are the community, right? So yes, yes, I'm going to explain that. So I mean, over the time doing research, I've found out that the best approach to solve a problem is to ask the people who have the problem for solutions, and that's what we call person-centered design or human-centered design. However, I would say that the key to address vaccine hesitancy in Nigeria or at large, the key things we need to do, first of all, we have to intensify community-based health campaigns, because I will now fall back to referencing the findings we had from the study. Lack of information and misinformation were major barriers. And how do you address lack of information or misinformation? Is to ensure that you have a very good community-based health education campaigns. In some areas, you can leverage on religious bodies and also traditional bodies to sensitize communities. There are some areas in Nigeria where they respect traditional people more than anybody. And there are some areas who respect religious leaders. So you leverage on these institutions to ensure that you educate people to clear off misinformation. That's one strategy I would recommend, but not just that I'm recommending, but I'm recommending based on the findings we got from the study. And then again, the second one is this. You know, different population have different way they are taken care of. An example of it is, if you are pregnant, there is an ANC unit that takes care of you, right? So do like the key population we studied, there is also a route, what we call the one-stop shops for them when they want to take their HIV drugs. For the prison, they also have the route where they take care of them medically. So where I'm driving to is, for us to address hesitancy, if you want to roll out vaccines, you don't bring in an entirely new people to start to vaccinate these people, but you integrate the vaccine service into the existing services. So because they are used to the people who take care of them and give them HIV drugs, or the ANC people, they are used to their nurses that take care of them. If you if you
I guess the network, it's hanging.
Vaccination
on
that ANC persons will take vaccines. If you take that route, then there's going to be a problem. Can you hear me?
Mr. Korfii, are you done talking? It was hanging, that's why. Are you done talking?
No. I want to summarize this part. So, okay. And again, yeah. So again, there's what they call peer-layered interventions, where you use people who have the same thing as I have to make me take some other things. So they believe that, like for the key populations, if you want to make a female sex worker get vaccines, you have to do that through a female sex worker. So we also have to invest in building champions, peer champions that are part of these communities or part of this class of people or part of these key populations, to use them to drive vaccine uptake. So then we can reduce vaccine hesitancy. So, and again, one key thing that I've noticed is this: in most vaccinations, healthcare workers do not really say what the vaccine safety or side effects looks like. And I believe that maybe because they are attending to so many patients. But for peculiar cases, like in the case of HIV, it becomes very important and necessary for us to start to integrate educating these people on what the side effects will look like, just to clear their doubt. I have mentioned that we saw cases where people complain or were concerned about vaccine and ART drug interaction. They are not medical persons. These people are not pharmacists. They are not pharmacists, so they will not know either these two things have, either the vaccine affects the HIV drugs or the HIV drug affects the vaccine. So there should be some sort of clear explanation at every point in time to let them know that this is what these things are. They don't affect each other. You can take them together. Yeah.
Thank you so much for that, Mr. Korfii. I saw something funny when I was reading the paper. It was on the statistics. Like, I saw, please correct me if I'm wrong, like people who are educated had low acceptance of low uptake. People who are educated among people living with HIV, they had low uptake of the COVID-19 vaccine. What is, as a researcher, what is your view? As what is your view on educational level and the uptake of the COVID-19 vaccine?
Okay, so I will start by profiling that well. So the educational profile of participants in the study, I mean, just like they have said, nearly half, about 47%, had gone to tertiary institutions. Then 39% have secondary education, while to 2.8% had no education. So from the research perspective, this shows that the study population was relatively educated. However, despite the high education attainment, there is still high vaccine resistance, just like you have pointed out, right? This indicates that education alone does not solve misinformation problem. Education does not solve distrust. It also does not solve fear. So even educated individuals, they are influenced by rumor, and you can just you know about the social media rumors. So even professors will get confused when you want to push something through Twitter, and they will think that these things are true. And then when you now tie it to political things, I mean, it becomes real to them, even when you know that this thing that they are saying may be wrong, right? But just pushing back to some key findings we saw from the research, that a significant association between education and vaccine uptake was observed, where we have participants with higher tertiary education were approximately 5 times more likely to be vaccinated compared to those without formal education. Yes, and then we are trying to say that this means that education improves health literacy and then also access to reliable information. But nevertheless, the hesitancy among educated participants demonstrates that vaccine decisions are influenced by social and the cultural and the political, then emotional factors. And these are things that are way completely beyond formal schooling. So you see that the way misinformation works, it tends to control your emotion, and it is driven through the social, how will I put it? It is driven through the social engineering, where they will make you believe what is wrong is correct. Yes. So to say that, just to summarize this context, I want to point out that being educated does not mean that the person will not decline or refuse to take vaccines. As long as that person does not have clear information or the right information about that vaccine, definitely that person is going to decline the vaccines, and that will lead to hesitancy.
Thank you so much for highlighting that formal education is not an independent factor in in decision making on COVID-19 uptake. So, Mr. Korfii, across decades, people living with HIV have been a particular group of concern across the world. Now, if tomorrow you are made the Commissioner for Health, what will you do differently for people living with HIV and AIDS?
Hey, I know I will not be commissioner for it anyway.
Are you rejecting the appointment before it's given?
No. I'm
One thing
not.
I've
I'm
learned,
not.
one thing life has taught me is never say
Yeah.
never, especially in terms of leadership. That stuff you are saying, it can never be me. Before you blink eye like this, is you.
I agree. I agree with you. I agree with you. So back to so back to what you have asked. So first, what I would do is to, like I've mentioned about integrating services into different platforms. And then I'm still coming back to this thing, because I believe that integration is actually a solution to most of our problems. So the first thing I would do is to invest in person-centered initiatives. People should come and say how they want to solve their problems, and not some board of people sitting in one room and then saying, take this thing to them. So because I believe that the things we take to people does not really solve their problems, but the thing they say they want is what solves their problems. So I will invest in people-centered initiatives where people will have to say, solve their problems themselves. And that lies in the word integration. So whichever service that we want to add, services should be layered. And there should be no uniform service across the different populations that we have. We have different populations that present diverse needs. So I will ensure that each population solve their problems themselves by telling us what they want and how they want it to be done. Then secondly, so since we are talking about people living with HIV and AIDS, what I've noticed so far is that, HIV and AIDS comes with a very big stigma. I know that the Western world may have been controlling that, but in the developing countries, it's a big problem. So another thing I would do is to invest in stigma reduction programs, and that will be done through healthcare workers. I have done a bit of work on the HIV space for like 5 years, and that work was done within these key populations. Though I work in the both populations, general population there, but you see that employed healthcare workers do not actually know appropriately how to handle HIV cases. They are still very stigmatized. So I will invest in stigma reduction programs, and that will be targeted at healthcare workers in public health facilities. Then another thing is this. I've said community outreaches, because you know why community outreaches is very important if you do it rightly. It's when you sensitize people over and over and over and over again that sticks to them. But if you don't sensitize people, one, they don't know about the thing. They only know when they come to the hospital. So I believe that there are some things that people should know, so that if it happens to them or it happens to anybody, it becomes very easy for them to accept it. I mean, if you maybe have conversations around this other key population, what are they called? You just tied around young people, teens. And they are also a different population in the HIV space. They call them something, so I've forgotten the meaning anyway. But if you have conversations with them, you will see that there is a big gap in the middle of all of these things across what is affecting them or what could affect them and their present situation. So those are the thing. But another key strategy that I think will be very helpful is this. For people who are living with HIV, they find it very difficult to come for their pickups on their appointment dates. Some also find it difficult to come for their viral load blood sample collection days. And that becomes an issue to manage them, an issue to manage them. So another best approach that I will invest in is mobile clinics, community-based clinics, where you carry the service to them in their communities. I understand the fact that the HIV thing is a very sensitive thing, right? But even with that, too, there are people who were set that you take the service to them, just like the way we do case findings. We take the case finding service to the community. That's where we test. So most of the HIV cases that you see are being managed in Nigeria today, most of them come from community case testing or community case findings, where we do the findings in the community. So if we can do the findings in the community, why can't we also carry the drugs and go and give them the community? So I will invest in finding a very suitable way of developing a mobile clinic, community-driven mobile clinic, that just so that we can avert the issue of I cannot come to the facility because there was no money. Yeah. So these are the key things that and some other more anyway, when I get to the position, different thing will come to my brain. But now I've not yet the commissioner. So but those are the strategies I think or the things that I would do differently. Yeah.
Thank you so much for that, Mr. Korfii Uebari. I'm sure whoever is currently the Commissioner for Health in River State will watch this video, they come across it and they try to integrate your recommendations into what they're already doing if they've not done it before. And I'm optimistic one day when you become the Commissioner for Health in River State, you'll be able to execute your recommendations excellently. Now, this is a question I usually ask every researcher that comes on this platform. What challenges did you face during this research? Because that's one part global citizens I'm trying to enlighten global citizens on. To know that research is not just research. There are challenges these people face while bringing new information to you. So what challenges did you face, Mr. Uebari?
So the thing is, studying these key populations is a challenge itself, right? You know, by the Nigerian law, they don't permit, or I don't know how to frame it, but the Nigerian law does not support men having sex with men. That aside, then for the female sex worker, it is very a difficult place to be. I mean, they are always very close, as same as people who inject drugs. So studying these people itself was a challenge. And it was a challenge because they are a group of people who have experienced different types of criminalization as well as discrimination. And building trust in you just coming, it's a difficult thing, right? And they don't, I mean, you hardly see them do open conversations around these things. That was one of the challenges itself, to have access to this population. Then the second challenge was around discussing sensitive topics like HIV status. And you know that is it tied to the community acceptance of people who live with HIV. So it takes, I mean, it took us different steps to be able to get this, because it was a focus group discussion, and you start to ask yourself, that's okay, I'm bringing in the other people into the conversation anyway. So it was one side quantitative, the other side focus group discussion. But whichever way, for them to open up to you to discuss HIV, their HIV status and management was a very key problem we faced during the research. Then another one that was very prominent was what we have talked about earlier, misinformation about COVID-19 vaccines, as well as COVID-19. So when you bring you bring up the conversation about, they will just tell you that no, you know, this thing does not exist anywhere. You know, those so for us to be able to clear them, I mean, to clear them to believe that all of the things they are saying about are just conspiracy theories that does not have basis, you know, was a lot of work. And then you will also see cases where people doubted the existence of the COVID-19 vaccine. So you start to ask yourself, how do you engage in having a conversation with somebody who first does not believe that this thing exists? So these were the challenges since we addressed. Right? We try to use the structure they have in place, their community, and then use the list, and then to ensure that we have access to them, and then conduct.
Okay, Mr. Korfii, now the last question. You've given us a beautiful discussion on COVID-19 and HIV in River State. How well is River State? I know River State, I don't want to be biased because I know someone from River State. Okay, how well is River State prepared for the next pandemic?
So I will start by saying the things that I know, right? You know, in the Nigerian context, politics controls everything. Yeah, but to the best of my knowledge, I will say that the state is well positioned to respond to future, if there will be any. They are well positioned to during the COVID-19 pandemic, but the preparedness is not entirely very well optimal. And then I pushed it back to politics, and then how things are being controlled in Nigeria at large. But again, the state has learned from COVID-19 experience, and there have been valuable experience over time from outbreak surveillance training, emergency response coordination, and risk communication, and all of the other campaigns. And the facilities and the government and all other development partners have been coordinating together, just learning based on what we faced during the COVID-19 vaccines. So now a lot of people have been trained as compared to when the COVID-19 pandemic came. Healthcare workers are well prepared now because they have learned what they never knew of. We have not experienced pandemic before now. not until the COVID-19 pandemic came. So people have been trained on case management, case findings, as well as outbreak reporting. And then these are things that has prepared the state for any future pandemic. So as I speak with you now, there is even an Institute of Infectious Disease Research and Development in the state. So these are things that have been put in place so that people can learn and people can see things that will build their skills and preparing for any similar thing that comes, just like the way COVID-19 came. Yeah. So I would say that the state is prepared, except politics will scatter everything that they have done.
Thank you so much, Mr. Korfii Uebari, for giving us a candid and extensive discussion on COVID-19 and HIV and AIDS in River State before the pandemic, during the pandemic, and after the pandemic. So, global citizens, this week we looked at the publication on COVID-19 vaccine uptake among people living with HIV and AIDS in River State. It's a simple publication. I usually encourage, one of the reasons for the Fajembola'S inertia for science and technology is to encourage global citizens to read, to increase the attitude of global citizens towards scientific articles, scientific publications, towards scientific research. So I believe if you want to have access to Mr. Korfii Uebari's publication, it's online available. The link is attached to what we usually post weekly. If you want to listen to it via audio only, it's on all podcast platforms. If you want to rewatch, please, it's here on YouTube. You can rewatch and share it with those you care about. Earth literacy is not an individual work, it's a teamwork. So that's why I usually encourage to share it with those you care about, because when you are taken care of and others are infected, you are absolutely not taken care of. So thank you so much once again, Mr. Korfii Uebari and global citizens, for joining us on this episode of Dr. Fajembola'S Opinion. We remain a platform where research meets understanding and legacy. Have a blessed week, everyone.
Thank you.
Thank you.